that we can make it
It's a real
work
pleasure
at
to
a
be here
government level,
today
and
to talk to this group. I think I've learned a lot more. I have learned a lot more from your group than probably work in these things.
Thank you so much.
Some of the things that we're doing over at Sloan Kettering to try to approach treatment of recurrent GIST with interventional approaches. So today we're going to talk about two things. Why even consider IR as a local regional therapy for metastatic GIST. And then we'll get into arterial therapies for GIST metastasis. We'll talk a lot about hepatic artery embolization. We'll talk a little bit about chemoembolization, and we'll just touch a tiny bit on drug-eluting chemoembolization. And then we'll then get a little bit into percutaneous ablation of GIST metastasis. So first of all, what's the rationale? And it really comes, the rationale for treating GIST metastasis comes from what we learned from sarcomas, and that's basically that resection of hepatic metastasis and sarcomas results in improved patient survival when compared to patients who aren't resected. Oh. Okay, good. So we learned this from our sarcoma population. If you can resect or remove the metastatic disease that's in the liver, these patients will live longer than those patients that were resectable. And furthermore, if you stratify patients by the degree that you are able to resect their metastasis, you can see the difference. Patients with no resection do worse. The ones who get intermediate resection do better. The ones who have complete resection do better. So if dental therapies are able to sort of completely eradicate the metastatic disease, you can do, and targeted therapies can't help, you may still do better by controlling the disease locally. And so we talked a little bit about these, and it is a little bit of a gross picture here, but when we talk about ablation, whether it's RFA or microwave, we're talking about heating the tissue in the liver and denaturing the proteins, desiccating the tumors, and basically rendering them non-functional. And in fact, if you look at the liver in a gross specimen after radiofrequency ablation, you can see that it actually starts to take on that gray appearance of actually cooked liver. And you can see in this gross specimen here, what we're actually seeing is that dried, denatured proteins of the liver, which are dead in that area. Let's talk a little bit more about what radiofrequency ablation actually is. Radiofrequency energy is just a form of energy in the electromagnetic spectrum. It's just like light, but it's in a different part of the frequency spectrum. And go through. So how does this work? You have a patient and you insert the radiofrequency probe into the target lesion. There's a radiofrequency generator that creates this alternating current. That alternating current creates an electrical friction within the ions that heats up the tissue. And then you basically, the tip of this needle gets to about 60 to 100 degrees centigrade, and it can create heat at a distance of about 1 to 3 centimeters. This electrical circuit needs to be completed, so grounding pads are placed on the legs, and then that connects back up to the generator, and that completes the circuit. Microwave ablation, on the other hand, uses it's similar in that it creates another part of energy in the electromagnetic spectrum. However, in this case, it's emitting microwave energy. Now, this is not dissimilar to the microwave energy that heats the water in a cup of coffee when you have a tea or coffee in the morning. So in this case, same kind of technique. We insert the microwave probe into the organ, in this case the liver, and microwave energy, rather than causing that frictional ionic energy, it actually causes the water molecules in the target tissue to spin, and that causes the water to actually boil. And so that heat then will denature the proteins, and because the microwave energy penetrates the tissue a little bit better, it will actually travel a little bit farther in the 1 to 5 centimeter range, and actually heat up the tissues quite a bit more. You don't need the grounding pads to get a little bit more efficiency of creating this energy. And basically, because the energy is radiated and not conducted, there's less of a heat sink, which means you get a more consistent ablation zone. And you can kind of see this in this, this is a schematic from an article that was written a few years ago, basically showing that in radiofrequency energy, once you reach that boiling point of water, you'll basically, we call it impede out. The tissue impedance will basically get too high and you cannot continue to deliver energy to the tissue. Whereas with microwave energy, because it's radiated, you can deliver more energy and create a larger area of ablation. Now let's turn our attention to hepatic artery embolization. If radiofrequency ablation is killing tumors by heating them, think of hepatic artery embolization as killing tumors by choking. Right? We're going to block off the blood supply to the tumor. How does that work? Well, the goal is to devitalize the tumor by causing ischemic damage. And just when it is metastatic to the liver, is a very hypervascular tumor. And so it draws most of its blood supply from the hepatic artery. So if you can block off the blood supply from the hepatic artery to the tumors, that will basically render the tumors ischemic. And when I tell patients when they see me in my office, I tell them, if I was to take my finger here and I was just to put a rubber band around this finger, it would stop getting blood flow to my finger. And in a few minutes, it would turn blue, and in about an hour, it would start to turn black, and in about 3 days, it would literally fall off. And that's what's happening inside the liver of these patients. So we take small particles, and we will inject them through a microcatheter into the tumors. And not only will we inject them into the tumors, which causes no more blood to go to the tumor, we'll actually block off all the blood vessels that go up to the tumor. And that will essentially cause ischemia within the tumor. The person blocks blood flow to your heart, part of your heart muscle, you're going to have a heart attack, and here we're going to have a tumor attack. So then eventually, like I said, that tumor is going to turn blue. It doesn't have any oxygen, it doesn't have glucose. It's going to die, and it's eventually going to shrink. Now, on the other hand, TACE, or transarterial chemoembolization, is a little bit different. In this case, we're devitalizing the tumor by delivering chemotherapy to the tumor. So how does that work? Well, you take a chemotherapy, what kind of chemotherapy? Well, in this case, there's only 2 chemotherapies that can actually be delivered to the liver in this fashion. One is doxorubicin, and the other is irinotecan, neither of which are particularly good for GIST. However, you take the chemotherapy, you mix it with a oil called thiazole, and that creates this chemoemulsion, or this slurry. And that will kind of slowly release the chemotherapy. And then you deliver this slurry to the tumor, and over time, the chemotherapy will leach out of the slurry into the tumor. Now, you still got to keep that oil inside the tumor, or it will kind of run out. And so you do put some particles into the blood vessels to stop the forward flow of blood to the tumor, but not in quite the same way that you do with hepatic artery embolization, just enough to kind of slow down the anterograde flow. And then over time, again, the tumor will shrink. We'll see some studies that look at this. And then finally, as time goes on, not right now, but maybe in the next 10 years or so, you'll start to hear more about DEB-TACE, or drug-eluting-mediated transarterial chemoembolization. So this is a very interesting technique because it has the promise to deliver other chemotherapy entities to the tumor, and at the same time, there's the promise to deliver it more accurately to the tumor. How does that work? In this case, again, the goal is to deliver the chemotherapy or the targeted therapy directly to the tumor. Basically, small particles can be loaded with a variety of different agents. Again, right now, mostly doxorubicin, but other agents are being considered. And once those particles are basically filled with whatever the agent is, and unlike that oil chemotherapy slurry, these particles will release the agent in a very slow and predictable fashion. So as time goes on, again, it will slowly elute the agent off of the bead, and it will deliver it to the tumor. So in this case, we are getting a combination of both effects. You can get the ischemic effect from the particles blocking the blood flow, and you're also getting the the effect of the targeted therapy or the chemotherapy directly to the tumor. Okay. So let's look at an example of one of these transarterial procedures. So here's a patient that has a very large GIST. It's metastatic liver. The patient already had treatment of their primary disease. When you sneak a catheter up through the groin into the liver and inject dye directly into the hepatic artery, you see a picture that looks like this. These are actually the blood vessels in the liver eating this gigantic tumor. Okay, so what are we going to do now? We go in with our tiny microcatheter and drive that microcatheter right up to the tumor. And there's the tip of the catheter right there. And then we inject particles. There we go. We inject particles into the tumor. And this is what it looks like immediately after the procedure. These white particles are the contrast mixed with the particles that are helping to, that are basically blocking the blood supply to the tumor. Okay, so then 6 weeks later, the patient has, we treated one of the big tumors here. 6 weeks later, we come back to treat another one of the big tumors here. You can see the same kind of picture. We inject into the hepatic artery. We get closer so that we can just treat the tumor itself. And let's look at the results. So here are the two tumors pre, and here's the immediate post showing the deposition of particles in the tumors. And then finally, this is what it looks like 4 months post. So why does it look so dark? That is the necrosis of the tumor. The tumor goes from being a sort of a solid tumor to a liquefied tumor, not unlike you see when somebody's treated with imatinib and the tumors kind of just sort of melt away and grows. You can see actually in this one doesn't have quite as good an effect as this one. You still see a little bit of internal structure there. Here's another example of a patient with just metastatic to the liver. They had this 3.9 centimeter mass at the dome. After hepatic artery embolization, this was only 3 months later. You can see, number one, the tumor is darker in color, meaning that it has necrosed. Number two, it's actually gotten smaller. And you might say, like, what does that mean? What happened to the tumor? Like, how did it actually get smaller? Well, the body has a set of garbage collector cells called macrophages. They're like little spiders that are traveling around the body. When this tumor necroses, it has to get rid of this dead tissue somehow. And so the body comes in and those macrophages start eating up the dead tissue at the edges. That leaves extra room for the good liver to kind of expand back into that area. And here's one more picture, another very large tumor here in the right posterior liver. And then as you can see, after treatment, we have the decrease in size of the tumor as well as increased the necrosis as witnessed by this lower density inside the tumor. So turning our attention now to ablation, here's a 55-year-old with metastatic GIST to the liver. You see they have just one small solitary lesion at the dome. Now that's going to be a difficult place to do a resection. You're going to have to probably take a whole segment. It's going to be right on the diaphragm, so that's going to be a tough surgery. Instead, we can insert that tiny needle actually through the lung and into the tumor. And you see the needle is going through the tumor. The tip of the needle becomes hot, as we talked about, with the radiofrequency energy. And notice we get the same kind of appearance here, right? A very low attenuation because blood can't go into that area anymore, right? The blood vessels there have been burned and destroyed. The tissue itself has been heated to a temperature that basically makes those proteins non-functional. And 5 months later, we get the same kind of appearance, that low attenuation or low density appearance of the dead tumor, and actually expansion of the good liver to fill in the space where the dead tumor was. Here's another patient, 77-year-old with GIST, with this solitary hepatic metastasis. They had already received imatinib, but this lesion was growing. These two dots here are just hepatic cysts. The patient underwent the RFA. And again, we see the very low attenuation picture here. And you might say, oh, why does that look bigger in this case? Well, when you have a very large lesion like this, and we look kind of somewhat immediately after or close to immediately after, we need to take a margin around the tumor, because if we don't take a margin, there could be little bits of GS stromal tumor around here that might grow back. So you always want to leave a little bit of a margin, and then as time goes on, the good liver will start to fill that. Here was a 4-year-old with sarcoma and had, this is actually a sarcoma. This patient doesn't have a GIST, but I show this case because it brings up the idea of what we call double kill. So some GISTs are very, very hard to kill with embolization or ablation alone. And so in those cases of those recalcitrant tumors that don't seem like they want to die with one treatment or the other, we use the double kill method. Now notice, this patient already underwent hepatic artery embolization because they got the particles in there already. And then what we do is we come in and we then put a needle on top of that. And so now we've already choked the tumor to death. And now on top of that, we're going to burn the tumor. And by doing both of this, it seems very medieval when I'm saying that. And you can see we actually get a much larger ring around this tumor. You can imagine this dark area surrounding the tumor. So we have a good margin. And then 3 months later, again, starting to shrink down. And by 12 months, it's probably, most of the dead tissue here is the size of the tumor, if not smaller. So we use the combination, that embolization and ablation, to provide that double kill effect to create a wider margin and a smaller area of recurrence. We don't use it all the time, but when we're concerned that we're going to have recurrence, that's what we do. So let's look at some data now. So patients with ablation of liver metastasis from GIST tend to progress less and survive longer than patients with other sarcoma histologies. So GIST happens to be a good histology and it actually reacts very well to ablation when you compare to other types of sarcomas. And this is true whether you're performing ablation, like we saw in the last study, or whether you do embolization. This is a study from Sloan, Kettering, where they looked at embolization of sarcomas stratified by GIST or non-GIST. And you can see the GIST patients actually did very well. The second slide shows that even for ones that are non-GIST, if you are a responder, meaning the first hepatic artery embolization showed a good response, you are likely to do well on subsequent hepatic artery embolization as well. We find that with our GIST patients that get metastatic disease after imatinib or sunitinib, they might get 1 or 2, maybe even 3 of these treatments over 4, 5, 6 years. And so, believe it or not, if you pick your patients well, and that means patients that have a very slow growth rate of their tumors, even if they failed 1 or 2 lines of targeted therapy, patients can have a long survival. In this study, that was in Asia, RFA of GIST metastasis in the liver, these patients had an overall survival of 90 months. And that's a long time. Another study kind of looked at basically overall survival and GIST survival rates, and you can see they're very high. 87 for the 5-year survival is about 85% and 100% respectively following liver ablation for GIST. It's all about patient selection. If you are picking patients who have small numbers of tumors with sizes that are in the, say, 1 to 3, 4, maybe 5 at the most range, you have a good chance of controlling the disease. Now again, turning back to hepatic artery embolization, this was one of the first studies looking at survival after hepatic artery embolization. And I think this is a pretty respectable 17.2 months for patients that underwent hepatic artery embolization. You can see the factors that were predictive of survival. For example, the patients who did respond well to imatinib, they tended to be the ones who did well with hepatic artery embolization. Patients who had smaller numbers of tumors and had lower extent of disease. You can see when the extent of disease is high, greater than 75% of the liver, those patients had 7 times lower, basically, odds of overall survival. One other thing I should point out is the presence of extrahepatic disease is not a good That does not portend well for patients with hepatic artery embolization. Well, that's kind of a no-brainer. If you've got disease elsewhere and you're treating it locally in the liver, you're not treating it as a disease, and you're probably preventing someone from getting the systemic therapies that they need. So if we look at chemoembolization, on the other hand, you'll notice that in this study, which was also from Asia, when they measured the overall survival, this I believe was in over, I can't remember how many patients, but I think it was about 20. They found that the median overall survival after chemoembolization, just metastasis, turned out to be almost identical at same 17 months. And so because of this data at Sloan Kettering, we say to ourselves, if adding chemotherapy to the beads doesn't help overall survival over the bland particles alone, why subject patients to the added toxicity of the chemotherapy, the cytotoxic chemotherapy? So we tend to do the plain, what we call hepatic artery embolization or bland embolization without the addition of chemotherapy on the beads. I think over time it will be very interesting if somebody comes up with a targeted bead, maybe a bead that has imatinib on it, maybe a bead that has sunitinib on it, maybe having a higher dose in the liver might be helpful. Right now, that's something that's way down the line, but it's something we think about as we design these new particles. So we did a study about, now I think it's about 4 years ago now, asking the question, how do we do when we treat patients who have just metastatic to the liver after they get imatinib versus after they get imatinib plus a second line drug, like sunitinib? Should we treat them with hepatic artery embolization in the second line, or should we treat them with hepatic artery embolization in the third line? And basically this is what we found. We found that in patients that get hepatic artery embolization after first line imatinib, those patients had a median survival of 14.9 months. If we treated patients who got hepatic artery embolization after first line imatinib, followed by second line sunitinib, actually these people did even better, 23.8 months. Now, this is a clear example of what we call a selection bias, right? The reason why the patients who got imatinib or got hepatic artery embolization in the second line after imatinib seemingly did worse is because they probably had more aggressive disease, or they weren't candidates for sunitinib, or they weren't candidates for other second line therapy. But what I think is interesting here is this idea that even if you intervene early, you can still do pretty well, right, in the 15 to 23 month range. And so this was one of the first times that we started to say, should we consider early treatment for some subset of patients? And you might say to yourself, why bother treating patients with a local therapy early when we have second line, third line, fourth line drugs to consider? That brought us to our next study, which was this. Let's imagine a patient who's diagnosed and with a GIST and is resected. Well, that's great. And then later they have an oligometastatic recurrence, oligometastatic meaning just a few tumors within the liver. Well, you've got a couple of options. You can give them systemic therapy, and they begin the systemic therapy and they continue, and that's fine. Or you could do some kind of local therapy to the liver, and in that case, they don't have to go on systemic therapy. They can continue, you control the disease, maybe they don't have any other disease. At some point in the future, they're going to recur, and then they have to go on systemic therapy. In this case, patients on systemic therapy for a long time. In this case, they had at least a period of time that was a chemotherapy-free interval. And for patients who are getting large amounts of targeted therapy, chemotherapy-free intervals can drastically improve their quality of life. Even if it's only for a year or 18 months, and they know they're going to go on sunitinib at some point, that's not the easiest drug in the world. And so chemotherapy-free intervals matter. So despite ultimately recurring and requiring systemic therapy, ablation of just metastasis could delay the need for chemotherapy, providing this extended chemotherapy-free interval. Let's see what that chemotherapy-free interval ended up for our GIST patients. So in this study, we basically, I actually had a student this year, he looked at all of our sarcoma patients and actually just literally this week, I said, I want you to subset out the GIST patients. Let's find this out. So actually, this is like not published. So in this group, we took the 14 patients out of our 100 sarcoma patients that had ablation, and we basically computed the chemotherapy-free interval for them. And in this case, we looked at both systemic and targeted chemotherapy-free intervals. And here's what we found out. First of all, out of those 14 patients, the median overall survival was 78 months after ablation of just metastasis. That was great. Clearly, this was, again, a very good pre-selected population that were good candidates. And then we basically looked at both the systemic chemotherapy-free interval, so any types of systemic therapy, and the cytotoxic chemotherapy-free interval. And so notice that after ablation, patients did have to resume their chemotherapy, but they got 7 months off chemotherapy. But the majority of patients, actually 3 out of 4 patients, never needed to go back on cytotoxic chemotherapy. So, we think this is actually a nice kind of a different endpoint to look at. It's very easy to say the whole story's on overall survival after local regional therapy, or the whole story's on progression-free survival. But a third endpoint that can be thought of as important for patients who have GIST, slow-growing tumors that have good treatments, is how long can we keep people off chemotherapy? We know they're going to eventually need it, but what we might be doing is delaying the need for chemotherapy and buying them time for some of these amazing studies that are going on with next-generation sequencing to find the real drugs that are going to make a big difference. So what am I leaving you with today? I'm leaving you with the idea that ablation and embolization are both viable treatments for patients who have just metastatic to the liver, and that image-guided local regional therapies like ablation or embolization could be considered even as early as second line in well-selected patient populations. Thank you, and I'll take any questions.
One question here. We have been talking about lesions in the liver. Is there something similar for lesions that are not in the liver, that are somewhere else?
Like the peritoneum, for example?
Is that if freezing is as successful as heating for those kind of tumors?
These are great questions. So the first question is, can you treat elsewhere? And it really, like most things in the New York, New Jersey area, it has everything to do with location, location, location. Right? So if you are near a critical structure like the colon or the bowel or the stomach, you can't. But if it's a lymph node somewhere, or it's a painful metastasis that's in the abdominal wall, yeah, you could treat them. I can tell you for GIST, that almost never happens that way. But for sarcomas, we often are treating in bone, or we're treating in soft tissues. So, yeah. The second question you brought up is an excellent question. The question was, does heating a tumor work better or worse than freezing a tumor, right? And you notice of course I have slides on that, but I didn't show you freezing of GIST tumors. And the reason is, what we learned about ablation, we call it freezing tumors cryoablation, is that in general, cryoablation works a little less effectively than heating a tumor. But there is an upside to cryoablation. When you freeze a tumor, you form a very distinct and visible ice ball. So you can watch that ice ball grow under CT or MR guidance, and when you can see it grow, you can help avoid those critical structures. So, for example, if we're close to a nerve, we might choose cryoablation because it will help us protect the nerve. We can't always watch that radiation extend out, and it can injure nerves. And now, not to say that you can't have nerve injury in both cases, but it tends to be less.
So maybe for other parts of the body, cryo is better than aerophage, for example?
So when you need to make sure that you're not injuring some critical structure, like let's take the kidney. The kidneys are a relatively small organ, and if you damage the internal, the hilum of the kidney, you can have urine leach, you can have bleeding.
Yeah.
So in the kidney, freezing tumors in the kidney tends to be the preferred method than heating tumors in the kidney. In the lung, I would say it's a toss-up. And in the liver, it definitely favors heating. And I think there are two reasons. Number one, the liver is very tolerant of being heated. And if you decide and you intend to, say, burn a 4 centimeter sphere around a 2 centimeter tumor, and it turns out to be 4.5 centimeters, there's a lot of good liver that can grow back, and over time it will just kind of fill in. The other thing about freezing the liver is if you freeze too much of the liver, patients can get into this very, we call it cryoshock, so they can get a systemic inflammatory response that looks a lot like basically shock. So we tend to only do that for very small tumors. One last thing, freezing tumors is much less painful than heating tumors in general. So if somebody has a very painful tumor, like that's on a bone, we would definitely choose to freeze it because it tends to reduce the pain much more. Think about it, getting frostbite doesn't hurt that much. Getting a big, terrible burn hurts very bad.
Right.
Yes?
I had an RFA done about in 2015, successfully performed, and that was in my liver. So you say survival is about 19 months from that. So my time is almost up. So what happens to that group of patients after the 19 months? Would they follow up RFAs, other type of treatments?
So just remember, whenever we talk about these survivals, that they're what we call actuarial survivals.
Right.
Meaning, like, it's not that, this is actually how long people live. Half the people live longer than that amount, and half the people live shorter than that amount. But yeah, we followed the difference between interventional radiology follow-up and surgical follow-up is very different, right? When the surgeon takes the tumor out of your body and it's in the bucket, he can look at those margins and he can say, every margin is clean, so the likelihood that those tumors are going to come back locally is very low. When we do an interventional procedure, we don't have the margin analysis. Right. The margins have to be analyzed by doing serial scans and inspecting those margins. And you saw how we're watching the tumors get smaller and smaller and smaller. If one little part of it started to get bigger and bigger and bigger, that would tell us that that part of the tumor has marginal recurrence, and the patient might need a retreat. So many of these studies, if you end up reading them, they'll talk about progression-free survival, so like the time to initial progression.
Right.
But that doesn't mean the patient could have been treated the second time. And the second term that you might see in these papers is called disease control. So if you had 2, 3, 4, 5 ablations, were you able to still be maintained at no evidence of disease? And I suspect you're one of those lucky people.
Well, I have a little bit of a problem is I'm allergic to contrast, so all the imaging is done without contrast. And I'm not so sure how accurate the imaging is.
Are you also allergic to MR contrast?
Sorry?
The MR contrast is called gadolinium.
Even that, I'm just done without any contrast.
Do you see the same radiologist every time?
Yes.
Probably could draw your insights from memory at this point. You probably don't need the contrast, right?
Well, I think what I would say is contrast is always helpful at finding subtle changes.
Yeah.
For some patients that are allergic to iodinated contrast, the kind that's used in CT, we actually do MR-guided ablation as well. And in MR-guided ablation, often we don't need to use any contrast because the intrinsic contrast in the liver allows you to see the difference.
Thank you.
I just wanted to point out when you talked about, because that's a very big concept of patients of saying, 90 months, it's been 83 months, crap, I have 7 months till I die, and how that's not what that is. You're looking at a Kaplan-Meier curve. It's a survival curve, and it's going to go down as patients drop off. But if you were to take all the patients in that study, and you had enough of them, and you plotted them, you'd see they'd be on a bell curve, okay? And this is going to be the median overall survival, and 1 standard deviation, 2 standard deviations, 3 standard deviations. There's nothing saying that you may not be on the very tail end of that curve, 3 standard deviations from the mean, 20 years from now. Don't not pay your mortgage because you think you only have 9 months left.
I mean, I'm another 10 years.
So yeah, exactly.
Yeah.
And you also have to
Great.
look at, it's not always random, so just keep that in mind.
Thank you.
I just want to ask, for a lot of these countries, they don't have access to like second line, third line therapies, and this seems to be a good solution Just wondering if you know globally if interventional radiology is successful and if there's ways to bridge knowledge to the radiologists in these countries. We have Kenya, we have Guatemala, like, some of these places don't have access. How can we move this to the field to help patients buy time?
Great question.
Yeah.
So, some of the original studies that were done in embolization were done using gelatin sponge. So gelatin sponge is just something that they use to stop bleeding. But it turns out if you don't have these fancy tiny particles that we use, if you literally just chop up gelatin sponge and mix it with contrast, that provides a very effective way of embolizing the liver. So in Thailand, for example, it's very common to just use gelatin sponge mixed with chemotherapy as a very common way of doing it. In some countries where drug-eluting beads are not very well used, like they just use regular gland particles, which are much cheaper. So I think there's a range of ways to block blood supply to tumors in the liver. The second thing I think, though, that you bring up is really the idea of understanding how to apply techniques that are used for common tumors, like hepatocellular cancer, which is a very commonly treated tumor with hepatic artery embolization, and applying it to rare tumors. When I first started at Sloan Kettering, my boss said to me, Joe, I've got two choices for you. You can either be the 8th guy on the hepatocellular cancer team, or you can be the #1 guy on the sarcoma team. And I
That's what you
said,
picked. Yeah.
I'll take sarcoma. I'd rather be working with patients who need access. And indeed, we are treating a lot of rare cancers with hepatic artery embolization to a lot of people's great surprise, right? That it actually works. What determines whether a tumor is really going to respond to hepatic artery embolization is how hypervascular the tumor is. And you can't always predict that. At the time of the angiogram, when you can see, when you inject the dye, and you actually see this nest of blood vessels around the tumor, telling us the tumor is very dependent on that blood supply, we know that when we block that blood supply, those tumors are
More vulnerable.
so I think really there is more knowledge to be had, and I'm glad I have the students here who are writing a lot of papers about this.
We're glad you chose sarcoma.
Yeah.
Yes, yes, we are.
All right, this is an excellent presentation. Thank you.